So this is Stan Checkett. He is 52 years old. He arrived in the ED and he's going to be going to the medical surgical floor. He was admitted for a small bowel obstruction originally, along with cramping pain in the stomach that was accompanied by nausea and vomiting. He was put on an IV and was given fluids along with an NG tube was inserted. He is allergic to Demerol, and he's currently on buprenorphine, which is 0.3 milligrams via an IV push, and ondansetron, which was 4 milligrams of an IV. He is a full code status. He has had a prior appendectomy and hernia surgery. Upon admission, he reported cramping pain in the stomach that started a couple of days ago, and this was also accompanied with nausea and vomiting. For his vital signs, his heart rate is 116 beats per minute. His blood pressure is 106 over 76 millimeters of mercury. His temperature is 99 degrees Fahrenheit, and his respiration rate is 28 breaths per minute. He is alert and oriented ×4, and his conscious state is appropriate. He is on an ECG monitoring system, and his heart rate was 116 beats per minute. He has poor skin trigger, and upon touch, his skin is cold. Like I mentioned earlier, his respiratory rate is 28 breaths per minute, and he has even breaths bilaterally. He does have hyperactive bowel sounds. An abdominal x-ray was ordered, and that pushed towards small bowel obstruction as the reasoning. His abdomen is distended, tender, and bloated. When he was admitted, his pain was a 4, and it was because of the cramping in the stomach. After administering buprenorphine, his pain was reported to be less. He is NPO. He has an NG tube, and it's on intermittent low suctioning. No dressings are reported. For his O2 levels, he's at 93% per 2 liters of oxygen via a nasal cannula, and the IV is in his right arm in the antecubital vein. Currently, it's 500 milliliters of normal saline is infusing for 30 minutes. He is not in isolation. He's a low fall risk, and he doesn't have any restraints. And it might be useful to run venous blood sample again, just to see if his electrolytes are stabilizing, returning to normal, or if there needs to be further precautions taken. And then currently he's on buprenorphine, 0.3 milligrams of a slow IV push every 6 hours as needed for pain, and that was last given at 11:06. And then he's also on ondansetron, and that can be 4 to 8 milligrams of an IV push every 8 hours as needed for nausea. His last dose was 4 milligrams at 11:07. He does have adhesions from a prior surgery as well, and that's the main reason for the transfer.